These folks are going to share with us what innovative work is happening on the policy side, federal, state, and local, to support some of these braiding and blending efforts, and hopefully some of the initiatives that you learned about today. Okay, I'll go ahead and introduce our panelists as they get mic'd up, so we have plenty of time for Q&A. With us today from far right, I think we're in order. Okay, yes, thank you. From the far right is John Tambernino from the White House Office of Management and Budget. He is part of the evidence team in the White House Office of OMB, where he helps lead efforts to promote evaluation and evidence-based policymaking across the federal government. He served in many, many roles at HHS previously. He was Director of Economic Support for Families at the Assistant Secretary for Planning and Evaluation. He's had many senior career positions there and at the Social Security Administration, covering safety net, healthcare, poverty, and disability issues. Next to him is Amy Clary from the National Academy for State Health Policy. She's a senior policy associate at NASHB, where she works on projects related to health system performance. Prior to joining NASHB, she worked for the American Federation of Teachers in DC, where she developed resources for healthcare workforce on the implications of healthcare delivery system reforms. Next to her is Sue Polis from the National League of Cities, who's responsible for directing the health and wellness portfolio for the National League of Cities as part of the Institute of Youth, Education, and Families. Her portfolio includes a wide range of issues: childhood obesity, building a culture of health through strong engagement of mayors and city leaders. She's also previously worked for the Trust for America's Health. There's a theme here as well as psychology. And has worked for AARP, so she understands the whole lifespan, so feel free to direct lifespan questions to her. And then finally, next to her is Len Nichols from George Mason University. He has there been the director of the Center for Health Policy Research and Ethics and a professor of health policy since March 2010. He's been previously intimately involved in health reform debates and policy development. I'm sure this is a familiar name to those of you in the audience, and been doing that work for over 25 years. He was senior advisor for health policy at the Office of Management and Budget in the Clinton administration. He's also worked at the Urban Institute and is currently on the board of directors for the National Committee for Quality Assurance, which we all know is really important in deriving quality in the value-oriented work that we're all doing. And he's also served as advisor to the Virginia Health Reform Initiative. So we have a very esteemed panel, a lot of deep expertise, and I'll just note that they're going to provide comments from their deep expertise and lessons learned, and not necessarily stating official positions unless they choose to state official positions. And I'm going to sit down and join the group, and we're going to similarly have a fireside chat discussion. Sorry, a little awkward. Okay, thank you so much. Okay, I'm going to go ahead and open up with a very open-ended question for you all to answer as you see fit. With what exciting initiatives are going on to facilitate braiding and blending? People have been stimulated by a lot of ideas of what's possible on state and local levels, and we'd like to hear from you all about exciting initiatives underway that maybe we haven't heard about. And I'd like to just really go down the row, start with you, John, on the federal level, and then we'll move down the row to hear about state and local initiatives as well. So, John, take it away.
Thank you, Sandra. A pleasure to be here. And again, nothing I say is to be taken as official policy or views of the Office of Management and Budget or the U.S. government. One important federal initiative that I'm involved with is the Performance Partnership Pilots for Disconnected Youth, which still trips me up. It's the first time I've said it correctly, I think. So it's known as P3. And P3, given this conversation, offers lessons, but also some cautions, I would say. P3 began under legislative authority that was provided in the labor HHS appropriations in 2014 and has been renewed annually through 2019. What P3 does is allow states and localities and tribes to propose demonstrations where they'll pilot cost-effective strategies to serve disconnected youth. Young people not in school, not working, involved in criminal justice, homeless, that sort of thing. the states and localities can propose to use funds under certain federal discretionary programs more flexibly than they normally would if they commit to a greater focus on performance. Their flexibility includes being able to braid and blend funds, to broaden the range of use of funds, to simplify some of the reporting requirements. P3 allows federal agencies to waive certain requirements, whether those that are rooted in statute, regulation, or other administrative policy. P3 is administered by a consortium of agencies. OMB helps to coordinate it, but it's a superb group of staff at the agencies who really have made it happen. The underlying rationale for P3 was that states and localities kind of know what they needed, and that they were really being stifled by federal requirements, at least in this program area. And if we could relax these requirements, it would really free them to kind of flourish, to do what they wanted to do, to innovate, to integrate, to focus more on outcomes, to achieve better outcomes, to achieve better efficiencies. Those were the expectations, and they've proven a bit inflated, actually, in terms of what we've learned. The uptake of P3 has been limited, both the response to the call for proposals and those that we were able to select as sites. In many cases, in preparing an application and then presenting it to the federal agencies, we realized that the barrier they were encountering was not rooted in federal policy, but rather in state and local policy. Or sometimes there was a perceived barrier, but not an actual barrier. The waivers that were requested were modest, typically just wanting to make kind of a marginal change in the use of funds. We also discovered, I think I most want to emphasize this, that waivers were not what was most critical, and the inflexibility is not what was most inhibiting states and localities. They realized, and we realized, that often they needed more federal guidance, technical assistance, resources to be sure, evaluation capacity, that sort of thing. So once the waivers were granted, that was not sufficient to really empower them to often make qualitative changes and improvements. The federal process for reviewing these flexibility requests and granting waivers was significant. We had to go through a thorough legal and policy review across all the affected agencies to negotiate with states and localities regarding the scope of the waiver, to develop new performance metrics and put in place more active performance management, to ensure transparency both to Congress, as was required in the statute, and also to the public, explaining why we're waiving this requirement, which was put in place, at least initially, with good reason, and to ensure that various protections were in place, including the appropriate use of funds. All of this was very staff intensive, just to do a handful of sites across several rounds of P3 projects. So that's the caution I'll emphasize at the moment, that P3 was an instance in which we had statutory authority for significant flexibility. We had genuine leadership commitment and staff engagement across multiple agencies. We promoted it actively to states and localities, and still the uptake was limited, the interest was limited, and where there was interest, it's been discovered that it was perhaps not what was most needed. Now, these are sort of preliminary observations. Most of these projects are still underway. The formal evaluation is forthcoming, but we've learned a lot already in at least this initiative to facilitate blending and braiding and other sorts of funding flexibility.
Thank you very much. Amy, you want to talk a little bit about state and local connection?
Sure, I'd love to. Thank you. So it's great to be part of this panel and this event today. One thing in talking with the state officials that I have the honor to work with that we hear frequently is that braiding and blending funds is seen by the state officials we work with as a strategy to build and sustain their programs and should not be seen as a replacement for adequate and robust funding of those programs. And so I just wanted to flag up front that that's something important that we often hear. But that said, the idea of braiding and sometimes blending funds across sectors is critically important, as we've heard from all the speakers today. And one of the areas in which we see this strategy coming to the fore is the intersection of health and housing. And so one state example that I'd like to highlight, and again, the experts on these topics are the state officials, the real people who are doing this work. In Louisiana, in the aftermath of Hurricanes Katrina and Rita, they developed a permanent supportive housing program that was the beginning of a long and fruitful relationship between the state housing and health sector agencies. And through working together, they were able to build the kind of trust that we've heard of that, for one thing, allowed the housing side to do housing and the health side to do the services part of permanent supportive housing. So really working out how each sector can play to its strength and not get in each other's way. And they've been braiding funds on the housing side, both HUD funds and state funds to do the vouchers and capital construction. There's also a lot of braiding of funds on the services side through a variety of CMS waiver funds through the Medicaid program, plus some SAMHSA, some Ryan White, some other funding, also coupled with community development block grant funding, including some from the CDBG disaster funds at the outset of the program. And what we've heard from those state officials, in addition to the importance of making those relationships, is that having those braided funding streams gives the program resiliency so that if a client, and of course this is all about the person who needs the services and needs the housing to live a healthy, productive life, if something happens to that person's paperwork and to cause an interruption in one of their funding streams, in Louisiana, the Permanent Supportive Housing Program can often work behind the scenes to temporarily use a different funding stream to keep the continuity going. And so it's a lot of work, and it's an ongoing and really interesting program to watch. But it really has a result for the people that they're trying to serve. So that's a fascinating example. Another quick example, we've heard a lot about braiding, and just an example of actually blending funds that I've heard of, and we've got plenty of experts, I'm sure even in the room here, is the Virginia Children's Services Act initiative, where in Virginia they actually are able to pool some state funds from state child serving agencies and use those together with braided federal funds. And the thing that struck me about that program is that the way it was explained to me by the folks, again, actually doing the work, is that system of pooling funds and then braiding some other funds allows them to create a plan of services that actually meets the need of the individual child or family instead of delivering the services that funding stream wants to pay for. And so that's, for me, a terrific example of how that can work, but that's not to say that it's easy by any stretch. And just quickly at the outset, another example, and this came to my attention more recently. We just recently did a case study on Lawrence, Massachusetts. And now I'm with the National Academy for State Health Policy. So you might be wondering, why Lawrence, Massachusetts? But we have at NASHP a work group that looks at hospital community benefits investing and policy. And I heard from state officials in Massachusetts, you should really look at Lawrence. And what's been going on in Lawrence is that the city's mayor's health task force is braiding funds from a range of sources and forging this they're just a juggernaut of community partnerships doing all kinds of upstream prevention there. And they're using funds from the hospital in the area, philanthropic funds, state funds, federal funds, and braiding them to do this tremendous work. But the state policy angle is that you've got, on the one hand, the Massachusetts AG's office, who recently came out with a new revamped nonprofit hospital community benefits policy guidelines that are in line with the state health improvement plan, state health priority guidelines. The public health department in the state oversees the certificate of need requirements for hospitals. And the state Medicaid program, Mass Health, certifies Medicaid ACOs and rewards them and encourages them to reward population health activities that are also in line with those state health priorities. And all of those factors led to the hospital both making these really community-guided investments that were identified through the community health needs assessment. Also, the Mass Health ACO, there's an ACO now in Lawrence that involves the hospital, the mayor's health task force, and other community partners. And so all of this is to say that braiding and blending is not just about breaking down silos across agencies. It's got this, there's a big vertical component to it as well, where meaningful, aligned, thoughtful state policies can really be the catalyst for action on the community level. And as we heard from our federal partners, thinking the same way that federal policy affects state policy as affects local. So really tremendous excitement and opportunity out there.
A terrific segue. Go ahead, Sue.
Thank you.
Bring us to the local.
Thank you. And we didn't really totally plan this, but I think our remarks you'll hopefully see as complimentary. And again, it's a pleasure to be here. I'm with the National League of Cities. We've been leading a series of conversations with mayors on social determinants of health. So exploring housing, the link between education and health, opioids, just a whole myriad of issues. And we keep, encountering with our cities in this work these barriers, particularly getting funding, working at the community level where the needs really are. So we approach this work in a broader framework. Braiding and blending is a strategy that we encourage our cities to use, but what we're really finding with our cities is we have to set a table. This is first and foremost about, identifying the needs in the community, finding the shared value proposition, bringing partners together. So that is really the first step. So what we've piloted it or are now taking to scale is an effort that we're calling Cities of Opportunity. And I'm mentioning this because while financing is a piece of that, if you don't have the table set to really help cities work across their respective agencies, we're not really going to make the progress that we need to make. So Cities of Opportunity is really about helping cities better leverage all of their assets across city departments. So we've had 12 pilot cities working in this initiative. New Orleans is one, and I want to just bird dog of what Amy was saying, in that New Orleans is benefiting from some of this. They are one of our cities that are further ahead with braiding and helping residents connect to services. The door there is largely through their low barrier homeless shelter. So that has eased, and that is, I think, an important story. In contrast, Lawrence, Massachusetts, we just had Mayor Rivera with us as part of our Mayor's Institute on Affordable Housing and Health. And while there are some great things going on there, they just don't have enough housing. They have a very high immigrant population. So while these things are working, it's not enough to just look at them in a narrow context. We have to help our cities with strategies across the board in this regard. So I think Lawrence is a great example, but I'm trying to make the point that it's just not adequate for the needs as well. So that's why we take this broader context of Cities of Opportunity. And we have to be agnostic at the National League of Cities. We don't prioritize braiding and blending over, community health needs assessment using community benefit or other financing strategies. Our role is really to put all these considerations ahead of cities, like pay for success, pay for performance. We try to lift up, all the ways in which cities are doing innovative financing. And so Boise is a great example of, the city's leadership role in convening all the right partners, prioritizing homelessness, working toward pay for success, which actually ended up being pay for performance because they couldn't quite get all the way there, but it's set the table now. In homelessness, building more housing for homeless, and now they're able to carry that through on other priorities like pre-K. So we're really trying to help our cities work across these different issues.
So what makes life exciting for the private sector? I would have to say, the truth is that so many people are talking about social determinants of health. In fact, I would say so many people have finally discovered social determinants of health. I would go so far as to say economists have even discovered social determinants of health. But of course, we're imperialistic enough, we think we invented this. And so we were the first to bring math to it. But anyway, we're doing this. Turns out, of course, social workers and public health nurses have known this stuff for about 120 years. So, who knew? But anyway, we're working on it. And I think the key learning opportunity, actually, in the healthcare sector was the readmission penalty in the Affordable Care Act, because a readmission penalty is a very serious hit, like 3% of Medicare revenue, which is big. And it's going to hit you if you don't get your readmission rate down. And of course, most of the country was pretty high. And that had the effect of making 4,000 hospitals pay an awful lot of money to a whole bunch of consultants to tell them the problem's not inside your walls, the problem is upstream. Upstream, what is that? And so they started talking to these social workers. And next thing you know, they're looking upstream and figuring out people don't have refrigerators for their insulin, right? People can't get to the appointments because they don't have transportation. People are eating real crap, and if we're eating at all. And so there's a whole bunch of stuff we could do relatively cheaply, oh my goodness, to save us real money. On the second learning opportunity, health plans. You know, let's look at dual eligibles. This whole business of expanding Medicaid also brought an awful lot of frail elderly suddenly and their managed care plans who are now at risk. What a concept. Economists did invent that. And so, you know, this whole idea of, oh my goodness, now I'm supposed to manage these people and they're not like these people I've been dealing with before. I got to go upstream. So there's a tremendous amount of learning with financial incentives involved, which gets me back to why all of these folks have led to me, and that is there's not enough money over there. You need the private sector too. And turns out, if you can link the self-interest of the major players in the private sector with the social interest in reaching upstream, there's a collaborative win-win here, and that's what we've been working on for some time now.
Well, thank you. I'm going to stick with you, Len, because you really set the table, as Sue so nicely said. And people are eager to learn more about economic models that might be implicated here. I know you've been thinking about this a lot, the wrong pocket problem, and writing about most recently the public goods strategy. And I'm wondering if you can just, in a nutshell, try to frame that approach for people in the audience.
Okay, thank you. Well, so basically, there are three elements to what we brought to this conversation, and I want to make it clear. I would not be in this conversation were it not for my co-author, Lauren Taylor. So the first trick is find a really good co-author. So Lauren, just to give you 30 seconds on her background, how many of you have heard of Elizabeth Bradley? Yeah, so Bradley did the original work showing that countries that spend more on social spend less on health. Lauren was her undergraduate research assistant. All right, Lauren was so smart, Betsy got her an MPH in 1 year. Then Lauren's boyfriend gets drafted by the Kansas City Chiefs. She goes to Kansas City, pretends to be an NFL wife while she edits Betsy's book. Did such a good job on Betsy's book. Betsy made her co-author, The American Healthcare Paradox, Taylor and Bradley. Then Shane gets cut, but it lasted 2 years more than me, so I'm still impressed to come back to the East Coast. She goes to Harvard Divinity School because she wants to change the world. So she finishes Harvard Divinity School, she can marry you and bury you, but it turns out people who finish Harvard Divinity School don't actually preach. What do? They try to change the world. So what does she care about? She cares about health policy. She's now in Joe Newhouse's program in the medical school doing healthcare policy. David Cutler is her advisor. The world is a very small circle. And I met her at a conference 3 years ago, and I said, oh my God, she was speaking for Betsy. I got to meet this one. So I go up and I say, hello, hello. I said, can you teach me this stuff? She said, well, maybe. So, you know, over a while. And so I said to her, you teach me social determinants. I will find us an economic model to incentivize investment. I had no idea if I could do this, but I knew she could teach me social determinants. So it turns out. So there are three real key things here. One is thinking about social determinant deficits as public goods. That is to say, if you solve it, if you invest in it, it will benefit more than one person at a time. That fact, right? Think about it. If you actually help the person not come to the emergency room a lot, it will help both the hospital and the health plan, right? So you got multiple beneficiaries. That creates what we in economics call a free rider problem. Every hospital knows where the homeless are. They could put a nurse practitioner out there this afternoon and do a whole lot of good, but it would also help hospital B and C, therefore they don't. So it's a free rider problem. Turns out economics has a solution to the free rider problem. And it was buried in highly mathematical general equilibrium theory in the 1970s, but also turns out that's when I went to grad school. I can read this shit. It's amazing, okay? So I find this model, and it's complicated, but it's got a little bit of game theory, a little bit of auction theory. It's not that complicated. If I can understand it, trust me, it's not rocket science, okay? But this model turns out to link the self-interest of those who would benefit from the intervention with the social interest of the intervention in such a way that they actually gain financially. Now, it's not going to solve every problem. It is not actually for every community. But go back to the readmissions crisis, add to it what we spoke about this morning, the opioid crisis. The key elements of making the model work is actually not the math, it's actually trust. It's actually a stakeholder coalition. These stakeholder coalitions have come to exist precisely to solve the readmissions problem, because you can't solve it one hospital at a time, you got to solve it together. And the opioid crisis. The opioid crisis is like a poster child for social determinants of health. And it's brought these sectors together. Therefore, all we need to do is to get in the room, and lately, with incredibly creative financing from the Commonwealth Fund, from the Episcopal Health Foundation, from Missouri Foundation for Health, and now the California Healthcare Foundation, we're going to get to teach this model to the country, and we're quite excited about that. And Lauren will be right there by my side, because she's the best.
Well, we can invite her next time.
Yeah, we should. We should. But I promised David I would only take 15 hours a week, so you got to limit the time.
Okay, great. Fantastic. Thank you all so much for your reflections. My next question was going to be, that people often refer to braiding and blending as just an accounting problem. What's holding us up for doing it more routinely? I feel like through all of our panels, we have a really good appreciation for what's holding us up. It's people, places, and things, essentially. And we're gonna try to digest that more and come up with some more policy strategies going forward. So what I want to do instead, with I think we have a little bit more time left for our panelists before we open it up for Q&A, is just again with an open-ended question, and anyone can take first stab. With all the lessons we've learned in the comments you've made in all of your areas of expertise, what is the next step? What can we be doing on the federal level, state, local level, private sector to take the next step to really allow some of these braiding and blending initiatives to flourish, to really invest in a productive way in determinants of everything? Anyone want to take first step? John.
Sure, thank you. Well, regarding P3, we've had discussions with the field regarding how something like that should evolve given the lessons we've learned, the potential for scaling it to a greater number of sites, potentially nationally, or scaling it to new areas outside of disconnected youth, and doing so with realizing what I was emphasizing, that capacity is equally important, sometimes more important than the issue of flexibility. Another new initiative I'd like to note that is building on lessons and will provide many lessons, hopefully, is new legislation that I'm helping to implement, the Social Impact Partnerships to Pay for Results Act, Zipporah, that was enacted last year. Zipporah allows us to pilot a pay-for-success funding model that was referred to earlier. And for those not familiar, in a pay-for-success funding model, the government is waiting to pay for whatever the program or service is until the end, when it's clear that the program or service has been successful in achieving the desired outcome. In the original model, there was a crucial emphasis on government savings, of implementing whatever program or service that would lead to improved outcomes, social and health outcomes, but also produce government savings through avoiding the sorts of things we want to avoid. And in doing that, providing a surplus, and that surplus would provide the funding that would allow paying for the initial expenditure. And that upfront funding would often be provided by private funders, whether philanthropic or investors. Zipporah provides flexible funding to support these kinds of models across states and localities. It provides $100 million available over a 10-year period for projects across 20 areas affecting low-income and disadvantaged persons, many of which would be amenable to the sort of social determinants of health sorts of focus and strategies that we've been talking about. Zipporah is administered by the Treasury Department in cooperation with 9 other agencies, and OMB is involved again. We're awaiting responses to a funding availability announcement that's public right now. What I would want to emphasize for this panel is that Zipporah provides a unique opportunity to have very flexible funding, to have a much longer period of time for a project and to observe outcomes, and therefore to be able to think longer term and to observe outcomes over a longer period. In particular, it allows us to test the proposition that we've all been emphasizing, that we can improve health and social outcomes by being able to more flexibly and strategically use resources, and in doing so, not only achieve these outcomes, but produce government savings. So Zipporah requires rigorous evaluation and accounting of the outcomes of these projects and very carefully costing out where the savings accrued across federal, state, and local levels of government, and allows us to just recognize those savings across perhaps 12 different domains, whatever, 20 domains, and then have this flexible funding that's used to pay for the service sort of in a way that reflects the savings that were realized in this scattered fashion across silos without actually having to capture them. Right, so it's a real opportunity to test what's been emphasized. The statute is very specific, so there's all kinds of ways in which it wouldn't fit a community or a particular project, but nevertheless, it's a real opportunity to innovate and evaluate in this space.
Thank you. Amy, you want to jump
Sure.
in?
Just a couple thoughts on where things are going. We've been seeing a lot of exciting work in states on accountable health entities, and that's a term that we use to describe a whole spectrum of different efforts in states where Medicaid and public health offices, along with some other state partners, are working together to really listen to the needs of communities and address them in a variety of ways. Some states are taking a pretty kind of Medicaid-centric approach. Other states are working from the communities up and building those. But it's a lot of the issues we've heard about already today, the need for strong community partnerships for data sharing, the ability to understand data across sectors. So I think those kinds of entities they lay a really important groundwork for this kind of braiding and blending work. And also just thinking ahead, I wanted to note that we had recently done an analysis of some governor's State of the State and inaugural addresses with support from our partners at the de Beaumont Foundation. And in addition to hearing governors say that they plan to address things like education and jobs and all these really important determinants that one might expect, we heard a lot of governors talking about climate change and a lot about housing. And I think all that is to say that as we're thinking about the future of improving health by addressing social determinants through braiding and blending, I think starting to think outside the panoply of social determinants we've been addressing and thinking more globally, literally, about things like climate change, I think will be on the horizon.
Yeah, and just to maybe piggyback again off of Amy's comments, at the local level, a lot of our emphasis in the work with cities across, again, opioids, housing, a lot of our emphasis is helping them be in more conversations with their state level entities. While there are some relationships and some great examples, those are the exception, not the rule. While we can, work with cities on things like healthy housing and abatement of lead and asthma trigger remediation, to really ease those burdens, they have to be in more connection with their state Medicaid agencies. And that's really where the relationships don't exist at the city level. And so we've been trying to be much more intentional about our work with the National Governors Association, the National Conference of State Legislatures. We have to help our cities build more of these connections and partnerships, because they are often feeling like they're left out, when those decisions are made at the state level. It's hard sometimes for our cities to get the funds where they're needed in the community to address the needs. So without those relationships, it's very hard to navigate that. So our quest here is to help facilitate those partnerships for cities. And I think to Len's point about healthcare entities, a lot of our small and mid-sized cities don't have health departments. They have to work with the county on those efforts, but they also are oftentimes overlooking the other health stakeholders in the communities, the hospitals, the health plans. And so that's another big emphasis for us, is really helping ease those conversations, getting those partnerships in place. And so as we think about cities of opportunity, a lot of our early emphasis has been on inviting a lot of our health stakeholders into those conversations with our cities to really begin to ease and build those relationships.
And the good news is those conversations are paying off. I mean, I would have to say there are a number of policies of this administration I'm not a fan of, but the ones that I am a fan of are the flexibility they're granting to Medicare Advantage plans, to MCOs, and to states. I look at what's going on in North Carolina right now. This is the best 1115 in the history of 1115s. Now, Jenny will yell at me. I probably shouldn't have said that, but because she knows about all 1115s, I just know the ones I like. But I do like this one a lot, and I like it a lot because they basically are going to allow Mandy Cohen in North Carolina to actually spend money on housing.
Can you say a few words about what they're doing
Yeah,
in that waiver?
So essentially, the idea is they are giving North Carolina unprecedented freedom to direct resources through their new MCOs. Why not? Let's do Medicaid managed care at the same time. But anyway, that's useful because it has the vehicles of plans who know what they're doing in this space as opposed to some other people. So the plans are allowed then to petition for and actually spend money on a number of domains that we would call social determinants in ways they have never been allowed to before. And Mandy has a process in place, and I would just say that the amount of freedom that she's got is unique in nature, and everybody's watching, because just like John said, we've got to evaluate this in a serious way, and we've got to make sure we learn what works and what doesn't work and why it did and didn't. But even that doesn't go far enough. Yes, she can spend money on housing, but she can only spend deposit and the first month, which is nice, but so what we need to do is take a little bit more freedom, and let's let Medicare Advantage do the same thing. And by the way, what about fee-for-service Medicare? That's where you think about what we really need is for this creativity and this vision to spread, and then hold us accountable at the local level to show exactly what the outcomes were. And not every experiment's going to be perfect. And not every experiment's going to pay off. But we're going to learn stuff from those experiments, and we've got to have that experiment. We're so close. Why not let it go all the way to let what people at the local level think? The key to our model, the key to all of this stuff, in my opinion, is the local stakeholder coalition. I love that management group they got over there in Maryland with the British accent. How'd they pull that off? But anyway. The local people have to decide where's the best way to spend our money, this money, our total pot of money, whatever braided, blended thing we got to figure out how to do this ourselves on a project we care about with people we trust. That's the way this is going to work. And we're so close and we're making progress. We need a little more freedom to make it happen.
Okay. Any other reflections on that? What could we be doing? Even if you want to shoot it back, and instead of saying in your domain what you think is on the horizon, what should your partners be doing? So from the state and local, what should the feds be doing, and vice versa?
I've worked primarily at the federal level for a really long time, so being at the local level is a whole different, view of this world. I think, as we talk to mayors and city leaders, these issues are in front of them every day. They don't have the distance that we have here in Washington, D.C. And while, I think there's a lot of good, things happening that we can build off of, it's only as good as people knowing about it, and it's only as good as people being able to operationalize it. So, I think more opportunities to help local communities set the table is, I mentioned that earlier, but, I think don't assume folks always know these things. We spend a lot of time on technical assistance. City folks are pretty busy, so we boil this down to pretty nuts and boltsy research briefs. And, once they're aware of it, you can begin to operationalize it. But I think awareness is still lacking, and I think that's part of all of our jobs, not assuming that, we do want the locals talking to their states, and we do want to facilitate that, but I think it has to work both ways. Some better collaboration around bringing state and local leaders together is something that we've been talking about with NCSL, because I think we're assuming too much, and folks are busy and have day jobs, and I think that's part of what we need to do is facilitate those relationships, because they don't happen automatically.
And I think one thing I would say for partners to consider is just to, first of all, to recognize the importance of Medicaid's core mission. The social determinants part is super important, but also the fact that Medicaid, with the budget they have in every state, has to provide care to all the people who qualify for it. And so I guess just being sensitive to, when you're talking with your colleagues in state Medicaid offices, being sensitive that they have to protect their core mission while still doing a lot of really innovative work to address social determinants. So acknowledging that Medicaid is important, and also taking the time when you're speaking across sectors and across levels of government to take the time to explain what you're talking about. When you say data sharing, if the other person doesn't really even understand the elements in your data dictionary, just acknowledge that it's okay not to know those things, And if you have those trusted relationships and the time and capacity to engage in that kind of learning, that's an important step.
Did you want to add anything?
Yeah, I spend most of my time thinking about what the Fed should do, actually, rather than states and localities, who I view much more sympathetically. I think the one thing I would emphasize is when you're dealing with federal policy, and many of you well know this, you're really having to think on that level, a national level, and thinking about what good policy would be overall. And often there might be a request by some locality to have some flexibility that in isolation makes sense. But at the federal level, you need to be thinking about precedent, essentially, and the extent to which that would make good policy nationally, and not just think about the ways in which that would be conducive to better performance in that instance, but the way in which it could cause problems in other instances. Now, of course, the point of a waiver is to be able to do something in a more isolated way, so that's an important mechanism, but just that. I mean, there's a different vantage point at the federal level that has to be thinking beyond that particular project where, even though it may very well make good sense there. I think I'd also just make the point that I appreciated the earlier panel was emphasizing the initiative that states and localities were taking, and that's good. I would continue with that. Often, as I said, barriers are not actual, they're perceived. Often it just takes the initiative and creativity to really press something, and it's the responsibility of the federal agencies to respond as constructively as possible to that, while again keeping in mind a larger set of concerns that inherently extend beyond the concerns of that particular locality.
And thanks for revisiting that notion of perceived versus actual barriers. I think that is a real challenge on all levels of this conversation and something we should revisit. But I want to make sure we have time for folks in the audience to ask questions. So let's go ahead and open it up, and we have microphones coming around. We have two people over here in this section. Thank you.
Does that mean it's me? Hi, my name is Alex Daddock, and I work for a group called FAHI, which works in Central Appalachia in 6 states. So we're based in Eastern Kentucky. So I wanted to ask, and this kind of goes on the preceding conversation as well with Pamela Brown. I don't know if she's still here, but that conversation about how there's sort of this culture and policy of compliance where we spend, and we see in lower capacity areas, like in parts of some of the smaller towns in Appalachia, for example, or communities that have lower capacity, just less ability to kind of thread the needle on all of these complex things. So I'm wondering, for the folks up right now, I was going to ask this of the last folks too, how can we get more back to a values of where we want to invest in people and places rather than exacting compliance on community health and social determinants, which tends to be sort of bringing up the people with the least resources, and lifting up their health. So I'd raise it more as a values conversation rather than a policy conversation, which I think we probably should be talking more about. Thank you.
So that may be a tough one to respond to, but what are some of the policy strategies to get back to values? Is that a fair?
Well, I guess what I'm thinking is I would like for folks to think about what they see needing to happen in terms of whether it's a political conversation, we work on housing, for example, as part of our group, just to clarify it, and it's is it $1.1 billion for this housing program, or 1.3 every year, and that's just really not enough, right? And so the social determinants are not being invested in. So we can fight about 1.1 or 1.3. We can fight about the funding strategies, but I'm just asking you to, I guess, take a step back on the value and think about the values conversation behind the policy a little bit.
And to maybe realign policy and funding approaches to reflect those values.
Yeah, I just want to hear people's thoughts.
Okay. Any thoughts?
I'll just jump in because, economists jump in anything. I would say, look, I think what you're talking about, at least what I heard, is how to make outcomes relevant to the compliance activity. You can't eschew the need to have oversight and accountability. We both agree to that. But your point, they're filling out forms, and Pam made the point too, they're filling out forms and doing all this stuff, terrified of being arrested when in fact they're. Okay, so I think it has to do with being very precise about what we want to measure, about what we want to hold results accountable for, and just focus on that. and focus less on a lot of stuff that we have to do. I think that's the key to under-resourced organizations. It's also the key to much better, I would say, alignment between values and actually the way we're spending our money. But it has to do with being precise and creative at the highest level of what outcomes do we care about. That's what I would say.
I'm struck that this is probably not a new balance we're trying to strike, so anyone else want to weigh in? Yes, go ahead.
Yeah, if I could, I think I'm respectfully disagreeing with the economist perspective there, though on other grounds. And also in response to the question, I think I would reformulate what I'm understanding the question to be, and that is to contest the notion that a focus on values and a focus on compliance itself is inherently antithetical. It's clear, I felt before I arrived this morning, I'm even more persuaded now that excessive requirements and a focus on monitoring and compliance can be stultifying and you lose sight of the purpose. That's true. But compliance and requirements and restrictions means a number of things. It means the targeting of funds appropriately and categorically, as we were talking about earlier. It also means protections, whether protections for individuals. It means thinking about the constitutionality and the legality of the means being used. This was front and center in President Bush's Faith-Based and Community Initiative, where the argument there, the initiative was to make it easier for faith-based organizations to provide social and health services. The argument given, partly it was a free exercise argument, but partly the argument given was that they often achieve these excellent results. And therefore, we should become more agnostic regarding the means used. And you had programs like the Prison Ministry Fellowship that involved worship. And they're saying, look, we reduce recidivism, ignore exactly what goes on in the program. Well, what was going on in the program was religious worship. It's not to say that shouldn't be going on in the program or in the prisons, but the question is, should federal dollars be used for that? And the objection that largely prevailed was to say no, even if that results in excellent outcomes, those aren't an appropriate means for the government to be funding, given the constitutional prohibition on establishment of religion. So that's perhaps a more extreme example, but it's by no means unique. You can think of other kinds of instances where these restrictions and requirements and some level of compliance and monitoring is partly in the name of values and partly in the name of very important moral principles that need to be limiting what we do. And an exclusive focus on outcomes, I think, is very problematical. I really appreciated the nuance in all the discussions this morning, but often I come into these kinds of discussions where there's a focus on outcomes and it becomes quite simplistic, I feel, and that there is this argument that we should be fully agnostic regarding the means used to achieve the ends and just focus on the ends. And on just basic philosophical grounds, that's problematical, really, to only be concerned with the ends such that any means to achieve them are justifiable. Final thing I want to note, and this is again just more of a government perspective, in terms of the need for ongoing compliance and oversight, some of which is going to be fairly extensive, is responsible public stewardship of funds involves using them appropriately, of course, but appearance matters. If funds are being used in a way that appears to be frivolous, that can really undermine the public's confidence in a program. And we see examples of that when GSA notoriously had a staff training and they brought in a comedian and a juggler and a bicycle mechanic and a clown and some other sorts of things. Is that our next panel? Actually, that was seen as an outrageous abuse of funds. It could very well have been an excellent way of producing higher staff morale and therefore performance, but it was seen as so egregious from the public's point of view that it was an unwise use of funds. So I could go on and on. But again, I'm absolutely recognizing, my colleagues and I recognize the need to shift to more of an outcomes focus. But when that gets simplified to the point of saying, can't we just dispense with so much of this monitoring and oversight and so many of these constraints, I think that becomes problematical.
You've clearly hit a very important topic that I think deserves a lot of exploration. Both the time is right, maybe to revisit these conversations and figure out also practically what the implications are. Let's just take a couple more questions, though, two before we have to end. Yes.
Great, thank you. Hi, I'm Cheryl Hollander from the American Hospital Association, but I spent much of my grad school days reading things you wrote, Len, so don't sell yourself short. Celebrity in your own right. I wanted to just revisit the Medicare fee-for-service population. A question for all of you, but John, maybe you have a little bit of inside info on CMS's recent primary cares initiative announcement, and especially the geographic population-based payment model that they're looking for comment on. I'm just curious whether you think some model like that incentivizes sort of total cost of care risk will actually or can actually create space for addressing social determinants, whether through blending or braiding or some other means, or what you think about, what sort of levers need to be pulled to really set that model up for success.
Well, you want to
No,
talk?
please. Go.
Great question. It does continue to raise the debate between John and I, which will probably go on for the rest of our lives, which is good. But I think the model does have great promise. I would observe that at some level you can trace that geographic version of the variant of it to a proposal that came through PTAC, which I happen to sit on, from the American Association of Family Medicine, right? So there are people really thinking hard about how to incentivize the ability to go and empower the ability to spend upstream. Both God and the devil live in the details, as I think we're debating here, and you got to have both present to make this work. You got to make sure that there's enough money in that total cost of care bundle to actually do something in a serious way, but it is absolutely the right level, in my view, of focusing on accountability and outcomes so that we can accomplish the objective. It's the right vehicle through which to drive it, yes.
John, any thoughts?
Jenny had one.
I'm no longer sort of active in the Medicaid space, so I don't want to speak to that. I'll get something wrong.
Okay, we have time for one more quick question. Go ahead.
Thank you. I represent the dreaded federal government here, but not an entity that works on the healthcare issues at all, except for funding facilities. We fund hospitals, and I'm with the Rural Development Mission Area of the U.S. Department of Agriculture. I have one comment, one question to what the FAHI representative was saying. I think we're talking about improving healthcare by addressing housing and education and clean water and those sorts of needs. It almost seems like we're trying to hold our nose the other way around, as opposed to advocating for adequate funding for housing and education and clean water and so on. I think that's kind of what I heard from the FAHI person. My question is, in the rural context, how do these models work? I heard folks saying engaging hospitals and helping meet the housing needs and so on to make them more affordable. As you know, there's a crisis in rural America with hospitals closing.
Yeah.
How does it work to have the community help the hospital stay intact and viable?
And we have time for just a couple brief comments. Go ahead. Sue or Amy, did you want to start?
I think we just met. We just did a convening with the HH Office of Faith-Based and Neighborhood Services on recovery around opioids and trying to figure out this, for folks in substance use and mental health and homelessness experiencing all these things are often connected, as we know. And from the value standpoint or question, I just wanted to sort of say, again, these issues converge in communities. I think we were talking about Huntington, West Virginia a little bit when we met. And we have really strong local leaders. This is a mayor in Huntington that, was in finance in Chicago and went back home because he felt like he could do something about it, and has been able to really, bring a variety of different funding streams into the community to try to make some progress on this issue of opioids. But these things don't live in isolation in cities. They are all connected, but I think there's also limits, being respectful. There's limits to what cities can do with some of these federal, funds, because they don't stretch to meet the needs of their communities, and there has to be better recognition of that. And again, it's not all about, I think outcomes to your point, but there has to be some better recognition that these are the same people experiencing these different things, and I think that's just often overlooked. And in rural communities, we've been talking to the Rural Health Association, trying to figure out where we have some common interests to bring local leaders from rural communities together. Noting the hospital shortages, we are hopeful that there's more that can be done with community health workers and social workers and things of that nature. But it's not, it is at the end of the day, like with the faith-based office and that conversation, who's in the community, right? And so a lot of times it is churches and it is that community that will bring in homeless people and take on that population. But how are they reimbursed for some of those services? So there's, with the HHS convening, I think we're hopeful that, there can just be more collaboration between faith-based leaders and city leaders to help meet some of that need. But it is the same population experiencing these things, and the funding streams just don't allow for the creativity that's sometimes needed to address these issues.
Thanks, and I just want to acknowledge that we're a little bit over time, so we're going to have to cut it short. But I'm happy to follow up with you on what's happening in rural frontier states. We're doing a lot of work there, and I'm happy to share that information with you offline. But I wanted to thank our panelists for a really dynamic conversation, and obviously more to come. Thank you all for your attention and for your great questions.
Thank you, and let me also thank the panel and just say that. When you raise a question, why don't agencies just work together to make things happen? As I think we've learned today, this is easier said than done, that there's a lot of really interesting things going on around the country to actually make that happen. And there's a lot of policy steps that need to be put into place and to be improved upon to make it happen even better. Our work in this area in Brookings continues, as does the work of other people around the city and around the country, some of whom you've met today, who are working in the same area. So it's an ongoing thing. You've got a sense of the flavor of the kind of conversations we've had here at Brookings over many, many months about these same issues. This meeting is being webcast now, and you can look at the panels later on if you wish and go back and relive some of the moments by going on our Brookings site and looking up events. On that events page, you will also see a link to a website here at Brookings, which also contains the publications, including blogs, that we've been doing in this area. And I'd certainly encourage you to have a look at that. I want to thank everybody who made this possible. I want to thank particularly the Robert Wood Johnson Foundation that did make this whole event possible, and also the work we've been doing at Brookings. And I know the work of a lot of people in this field. Robert Wood Johnson Foundation is very active in this area, as I think many of us know, not just in terms of the policy work, but actually helping to start up some of the things around the country that is happening and are in the leading edge. So it's been very important to that work. I also want to thank the panelists, all the panelists that took part today, and also the working group, the group that included the moderators and some others on the panels that helped pull this together and help us in this area. As we end, I'd ask you to do two things. One is, as you leave here today, go tell other people about this issue. Get them excited about braiding and blending. It's probably not at the top of their immediate areas of gratification, but it's something they should know about and be aware of, particularly in the policy field. So if you know somebody who works for the government, if you know people who work for agencies, please direct them to that events website that I mentioned that will allow them to look at this and also allow them to see the other work that we're doing. And then finally, I want to just ask you to join me in applauding everybody who took part in this today. They'll be around, I know, for a few minutes, so if you had questions, you can have some of those answered. But I'd like to ask you to give a round of applause for everybody who took part in this today. And thank you very much. Enjoy your...
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.